Dear colleagues, my name is Barham Abu Dayyeh. I'm the Director of Advanced Endoscopy, Professor of Medicine, and Vice Chair of Innovation at Mayo Clinic in Rochester, Minnesota. It's a pleasure to talk to you today about the state-of-the-art updates on endoscopic bariatric and metabolic therapies. These are my disclosures. Today, we're going to highlight advances in the field of endoscopic bariatric therapies. We'll start by talking about the concept of combination therapies as the first advancement in the field. This is a nice publication published in eBiomedicine, where they looked at a concept of a combination intragastric balloon plus a duodenal jejunal bypass liner and compared it in a rat model to a row-Y gastric bypass. You could see that compared to a sham, both the row-Y gastric bypass and the sleep balloon concept have similar weight loss, similar improvement of visceral adipose tissue content, a similar effect on blood glucose levels and insulin, and also similar rise in the plasma GLP-1. If you look at fat deposit, ectopic fat deposit in the liver and skeletal muscle, you could see in the sham-operated rats, there is significant fat deposits both in the liver and skeletal muscle, compared to a row-Y gastric bypass and the sleep balloon combo, that there is a resolution of fat deposit in these organs. What's interesting, however, about this concept, once they looked at the potential mechanism of action, you could see that it's quite divergent. So this is the sleep balloon, this is the row-Y gastric bypass, and this is the sham-operated rodents. You could see with the sleep balloon concept, when they gave the rodent an radioactive ingested meal, and they looked at the transit time in the upper GI tract. This is 5 minutes and 120 minutes. You could see that the sleep balloon concept was associated with significant delay in the emptying of that meal, and most of this meal is still sitting in the fundus of the stomach at 120 minutes. When they looked at the row-Y gastric bypass, you could see that there is a rapid transit into the small intestines within 5 minutes, and very little of that meal is still in the gastric pouch, and this is the sham-operated rodents. So both have different effects on physiology or foregut physiology, but led to the same weight loss and metabolic benefit, which is a very interesting finding. And that finding now is the basis of developing combination endoscopic bariatric and metabolic therapies. This is a pig study that we published. It's where we randomized animals to either getting the gastrojejunal or the duodenal jejunal bypass liner versus getting intragastric balloon. And after a few weeks, they crossed over to get the combination therapy. And what we demonstrated with the study is, compared to control, that the combination device resulted in more significant weight loss compared to the individual devices, and that the potential metabolic benefits of the combination technique is better than the individual. So in a real world scenario, how would this translate? It translates that you could place an intragastric balloon, for example, for a period of indwelling time of about a year. Patient would lose significant weight, more than 10% total body weight loss. At the time of balloon removal, you could now contemplate placing a duodenal bypass liner to augment the weight loss and capitalize on the weight loss independent pathways of bypassing the small intestines for metabolic benefits. Now, it's very interesting that the concept of utilizing the proximal small intestines as a weight loss independent mechanism to have metabolic benefits, especially on fatty liver disease. So here you could see that this is an experiment published in Annals of Surgery, where you bypass the duodenum and jejunum with a duodenal jejunal bypass. compared to creating a gastrojejunostomy without blocking the pylorus. That means you're not bypassing the proximal small intestines. With this procedure, you have dramatic improvement in type 2 diabetes in rats, and I will show you evidence in fatty liver as well. With this experiment, there is no effect on diabetes or fatty liver, indicating that a bypass of the proximal small intestines plus a gastrojejuno anastomosis could provide a promising procedure for the treatment of type 2 diabetes and fatty liver disease. And if you could now, you could see that we are in reach of replicating this procedure endoscopically. This is the evidence showing that compared to a sham-operated rats at 10 weeks after high-fat diet, that the duodenal jejunal bypass was associated with significant decrease in lipid accumulation in the liver. Thus, it represents a very promising target for the treatment of non-alcoholic fatty liver disease. So this is the endoscopic analog of this procedure that we're working on, with the addition that this analog not only bypasses the proximal small intestines in a fashion similar to the duodenal jejunal bypass, but it also delays the gastric emptying by blocking the antrum in order to have to activate the gastric pathway, so it will have weight loss dependent and weight loss independent mechanism of actions. And those of you in this conference that do endoscopic gastrojejunostomy, you could see that this is an easily done procedure endoscopically. So we start by placement of a lumen opposing metal stent or an axial stent. Then we deploy this device that sits in dynamic equilibrium anchored at 2 points in order to occlude the proximal small intestines and delay the gastric emptying as shown in these figures. This is called a single anastomosis endoscopic gastrointestinal bypass system for the treatment of metabolic diseases. This is from our animal experimentation, showing that here's your Axios gastrojejunostomy. This device deploys similar to a PEG tube, blocking the antrum of the stomach and providing a proximal small intestinal bypass. So the second advancement in this field is the gastric remodeling techniques are gaining wide adoption and are getting better and better as far as durability and impact on weight loss and comorbidities. This is the spectrum of obesity care. You could see from the levels of invasiveness on the x-axis to the efficacy that we had a gap between lifestyle intervention and bariatric surgery. There's been implantable devices like intragastric balloons and sleeve liners, but we've been mostly still operating in this neighborhood of 5 to 15% total body weight loss. But now the promise of the gastric remodeling techniques is that we're going to augment both the magnitude of the weight loss, the durability of the weight loss, in order to be operating in this zone while maintaining the safety that an endoscopic procedure provides. The two gastric remodeling techniques that we have currently is the endoscopic sleeve gastroplasty and the post 2.0 procedure. With the endoscopic sleeve gastroplasty, we use a full thickness endoscopic suturing device in order to imbricate the greater curvature of the stomach in order to tubularize the stomach and reducing its longitudinal axis. With the post 2.0, instead of using sutures, we use these nitinol plications. Each plication reduces the stomach by about 6.5 centimeters. And if you administered a series of synchronous plications starting at the incisura all the way to the proximal stomach, you have the same effect of tubularizing the greater curvature of the stomach and shrinking the longitudinal length of the stomach. This is what you get with the endoscopic sleeve gastroplasty. As you could see, there is a shortening of the greater curvature of the stomach, and there's also tubularization of the greater curvature of the stomach with imbrication of the full thickness gastric wall as seen in this MRI image. The appealing part of these procedures is that they preserve the function of the organ, both as far as innervation and vasculature. This is dynamic MRI with after an ingested meal, after endoscopic sleeve gastroplasty, showing that the stomach is peristalsing, the nerve and vasculature of the stomach is preserved. Therefore, these procedures provide an anatomy-sparing approach to the management of obesity and metabolic disease with little long-term consequences or negative consequences on health. So the first advancement in the field of gastric remodeling is the evidence is quite mature, both from real-world and now randomized controlled trial. This is a meta-analysis published a couple of years back, including about 1,700 patients. Currently, there is more than 20,000 procedures done globally. You could see that the results are quite homogeneous in that at 12 months, you're realizing about 17% total body weight loss. The weight loss observed at 12 months is maintained for 2 years with a very low incidence of serious adverse events at 2%. Most of these are managed endoscopically with no requirement for surgery or intensive care management. This was also replicated in the Brazilian consensus with more than 1,800 patients showing total body weight loss of about 18% at 12 months with an incidence of serious adverse events of 0.8%. Now we have completed a randomized multi-center clinical trial, including 9 US centers, both gastroenterology and surgery, both in academic and private care setting. And I could share with you the early results presented in IFSO this year, in that the study was positive, showing about 50% excess weight loss at 1 year, compared to about 5% excess weight loss in the lifestyle arm, giving a differential compared to lifestyle of about 45% excess weight loss. Responders rate was 77%, with a total body weight loss in those who responded of about 16.3%, as shown here. The very good thing is that despite the pandemic in year 2, affecting the crossovers and affecting the longitudinal follow-up of those randomized to endoscopic sleeve in 1 year at first year, that the vast majority of the weight loss achieved at 1 year was maintained at 2 years, despite the restrictions of the pandemic. And those who got the endoscopic sleeve gastroplasty as a crossover in year 2 achieved exactly the same weight loss as those who achieved it or who got it in the first year, indicating that these results are robust and that the endoscopic sleeve gastroplasty results in effective and durable weight loss and impact on comorbidities. Hopefully, all the details of the trials will be presented at DDW this year. The second advancement in the field of endoscopic gastric remodeling technique is that drugs are getting better. And now we're embarking on combination of endoscopic sleeve gastroplasty, for example, and medications like the GLP-1 agonists, like the semaglutide, in order to even push that weight loss magnitude and durability closer and closer to bariatric surgery. This is a randomized trial published or presented in DDW by Hoff and colleagues, where they randomized 61 individuals into receiving endoscopic sleeve gastroplasty. And then after 1 month, they allocated them to either getting a placebo or getting semaglutide, and they followed them for an additional 11 months as shown in this schematic. You could see that the total body weight loss with the endoscopic sleeve gastroplasty alone was about 19% total body weight loss. The magnitude of the weight loss was augmented to about 25% with the combination therapy. So you could see that the appealing concept, even more than the results that we're seeing here, is that you'll get significant weight loss with the endoscopic sleeve gastroplasty alone at 1 year. But then after 1 year, you could contemplate adding the GLP-1 agonist in order to augment the durability and the magnitude of the weight loss in year 2 and year 3 after the procedure, now resulting in weight loss similar to surgical procedure, but with the safety and the anatomy preserving nature of endoscopy. The third advancement is we'll continue to hone the techniques in order to enhance the durability even further with these gastric remodeling techniques. We mentioned the primary obesity surgery endoluminal 2.0. This is a multi-center prospective trial that was conducted with Mayo and two centers in Spain, both at San Gennaro University and Tecnon in Madrid and Barcelona. We used the USGI incisionless operating platform that introduced these plications that are supported by nitinol baskets, and these are extremely durable plications that would last for a very long period of time. The concept of the procedure is as shown in these videos. We start at the level of the incisura. We introduce the G-prox in order to acquire about 7 centimeter plication, and then deploy these sutures supported by these nitinol basket, or what we call the snowshoe baskets. We administer a series of synchronous plications starting at the incisura, going to the proximal stomach, thus tubularizing the greater curvature of the stomach and reducing its longitudinal length as shown in these videos. And we really do that very well. This is the stomach before the post-tube procedure. You could see that it's about 5 vertebral bodies from the fundus to the incisura. And this is the stomach after the post-tube procedure, reduced in length to about 2.5 vertebral body, and the greater curvature is tubularized as shown here. This is the stomach before, and this is the stomach after. And as I indicated before, the durability of this procedure is quite good. This is 24 months. Upper GI serous, you could see that all of these plications along the greater curvatures are intact with a sleeve-like endoscopic gastroplasty with durable results in the long term. Now we also have automated endoscopic sutures. This is from a company called 90 Notes, that with the touch of a button, you will introduce a spiral continuous suture to create multiple full thickness plications in the stomach. This is promising in that it could scale endoscopic gastric remodeling techniques to colleagues with average endoscopic skills, and the learning curve of this technique probably is going to be very short because it's the most of the process is automated. The other advancement is we are continuing to tweak the endoscopic sleeve gastroplasty to introduce even more durability, and we do that by following the principle that if you expose the submucosa and muscularis and approximate the muscularis levels together, you will have enhanced healing of the configuration of the gastroplasty and thus enhanced durability as shown in this schematics. So to that end, we've adjusted the endoscopic sleeve gastroplasty, or we're exploring adjusting the endoscopic sleeve gastroplasty to this concept of auscultating circular gastroplasty. And the premise of the auscultating circular gastroplasty that we published recently in Gastroenterology in 2021 is to create a anterior and posterior cap-assisted EMR defects to expose the underlying muscles. This is the auscultating circles. We ablate using APC in between, and then we use endoscopic sutures in the same endoscopic sleeve configuration in order to approximate these auscultating circles to allow for approximation of these EMR defects and enhance healing of the sleeve configuration. I'm just going to give you a flavor of the actual procedure. This is, you could see here is the anterior, posterior EMR defects. This is the APC ablation in between, and now we use these U-shaped sutures as shown in here in order to approximate these plications in a standard endoscopic sleeve gastroplastic fashion to enhance the durability or healing. Here you could see we're marching along the anterior, then greater curvature of the stomach. We are engaging the helix in between the EMR defects, not in the muscular defect itself, to avoid the risk of perforation. And that's the beauty of these auscultating circular gastroplasty compared to, for example, to a wide field ASD, is that that safety of engaging the helix in between adds a lot of benefit. And now we're going back toward the greater curvature of the stomach and finalizing this O-shaped sutures anteriorly. We cinch, and you could see with the cinching process, these circles auscultate together, creating a gastroplasty as shown right here. So if you look at the durability of the response, this is a few months later, you could see there's nice healing and fusion of the gastroplasty. You don't see much sutures there because the sutures have been incorporated within the healed gastroplasty configuration. And now you have a nice, well-healed, tubular stomach with restricted reservoir as far as volume and accommodation, impacting both satiety and satiation. The third advancement in the field of endoscopic, bariatric, and metabolic therapy is these novel procedures and novel energy modality that allow us to treat type 2 diabetes and fatty liver and other metabolic diseases as well. So part of the novel targets of endoscopic, bariatric, and metabolic therapy is the fact that we know from really good science in that intermittent fasting has significant metabolic adaptation and improvement in metabolic parameters through the pathways I'm showing you here and reviewed in the New England Journal of Medicine in this review. The part of intermittent fasting that makes it difficult is that people feel hungry and they cannot follow an intermittent fast in order to realize its metabolic benefit that are plenty. So this device called the PulseSense device, it's designed to work in the fasting state in order to indicate fullness by activating the stretch receptors in the proximal stomach using this umbrella type of stent mechanism in order to allow people to follow an intermittent fast successfully and realizing the metabolic benefit of that intermittent fast. This is the device in place. As you could see, in the fastest state where the stomach is collapsed, this device is putting pressure at the cardia of the stomach. It does not bridge the GE junction, so gastroesophageal reflux disease is not a big component of this because the lower esophageal sphincter is functional, as you can see from this video. But the idea is you're putting stretch on these mechanical receptors in the proximal stomach that communicates signals to the brainstem, indicating satiety and satiation. Thus, the patient could follow successfully an intermittent fast. Innovation in small bowel technology that targets fatty liver disease and type 2 diabetes, as these are the current diseases affecting most of the world population, as shown in this figure, making rise to this new field of evolving gastrodiabetology. Gastroenterologists are going to find themselves in the near future treating these metabolic diseases such as type 2 diabetes and definitely fatty liver disease. The reason we're going to find ourselves doing that because truly the maestro or the conductor of the orchestra that organize the metabolic signal is the duodenum. This is published in the Proceeding of the National Academy of Science from the Hopkins groups, showing this intrinsic or a significant innervation of the duodenum in order to conduct the metabolic signals, and this could be a target for the treatment of metabolic diseases. Simply stated, in states of metabolic diseases, this duodenum becomes ineffective in organizing the metabolic signal. So the question is, could you take this ineffective duodenum and regenerate its layers, both the mucosa, submucosa, and even the enteric nervous system within it, using different modalities in order to recapture metabolic health and making this conductor effective in organizing the metabolic signals. This has been the target of multiple technology, including laser-based technology, heated water. This is the fractal technique that ablates the mucosa. But now we have tools to allow us to ablate not only the mucosa, but to go deeper to regenerate the enteric nervous system responsible for these signals, because with the use of these tools that utilize a new energy modality called electroporation or pulse electrical field, we could ablate the structure without administering heat. That means we do not affect the extracellular matrix. We don't denature proteins around that extracellular matrix. So we could ablate the entire structure with no risk of thermal injury or perforation. And the premise of electroporation or pulse electrical field is that you administer a high density electrical field in the neighborhood of about 1 kilovolt per centimeter square, but you administer it only for a nano second. So you're in this zone of irreversible electroporation. And with that, you create multiple holes in the phospholipid membranes of the cell. So the cell lies through the process of apoptosis rather than having coagulative necrosis. Therefore, you could truly ablate a structure without thermal injury or heat. And the premise here is, again, this electrical field that or the pulse electrical field introduce these nanopores in the phospholipid membranes of the cell, and the cell bursts through the process of apoptosis rather than coagulative necrosis, as shown here, thus regenerating the structure without the use of heat. So this procedure is being developed by a company called Endogenics in Minneapolis. Currently, it's in humans in 3 countries, and we're starting the FDA trials in the US as well with this technology. But the premise of this technology is using a flexible circuit with no need of submucosal lift, because there's no thermal injury, in order to ablate a long segment of the duodenum that is long, and to ablate deeper beyond the mucosa to the submucosa and nerve ending surrounding the duodenum, in order to recapture metabolic health of the and treatment of type 2 diabetes. This is a technology in a patient. You could see it's pretty simple. You administer the device, you deploy the flex circuit. There's no need of submucosal lift. You apply suction in order to collapse the duodenum around the opened flexible circuit, and you just press a button, and now you're ablating with, or you're regenerating that segment of the duodenum without the use of thermal injury or heat. So this is a very exciting advancement in our field that could truly revolutionize how we manage type 2 diabetes and fatty livers and other metabolic diseases. So the final segment is endoscopic, bariatric, and metabolic therapies are truly gaining adaptation and recognition as a valid treatment option for obesity and metabolic diseases. This is a recent randomized trial published in The Lancet. So now we're publishing in the general medicine journals, and to increase awareness that this is a tool to augment the spectrum of care for the obesity, or for the patients with obesity. Now, endoscopic bariatric metabolic therapies are making it to societal guidelines. This is from the AGA published in Gastro, and the red journal shown before. And this is from the ASLD, or the Association for the Study of Liver Disease, about these technologies. So in conclusions, the GI tract is front and central in weight and metabolic regulation. Endoscopic, bariatric, and metabolic therapies will play a major role in the management of obesity and its metabolic complications. The future is bright with multiple innovations in the pipeline. And with that, I conclude, and thank you for your kind attention.